Okay, I think we should get started. We have about 18 folks on, which is not too bad. So thanks for joining us once again. And thank you, Rick. So again, just going through our housekeeping issues. If you have any technology concerns, please contact Rick with the details there, and you can contact Claire or me for any other issues. Next slide. So today, I will continue to facilitate. We have two case presentations. Linda and I will be presenting our cases after we hear a little bit about telehealth from Kathleen and Kelsey. And Karen, I hope, is here with us this morning as well to discuss the two cases that we have upcoming. Next slide. These are our disclosures. I don't believe there are any new disclosures related to today's content. You can look these over at your leisure. Next slide. A reminder once again to use patient-centered language to the greatest extent possible. It takes some practice and getting used to, but I believe we're doing a good job. So you can look these over once again as well. Next slide. And we are ready to begin. So Kathleen, please take it away.
Good morning, everyone. So I and Kelsey, we are tasked with just reviewing some advances in telehealth, and I'll review our objectives. Next slide. So first, we're going to just kind of provide some background information on the growth in telehealth and for diabetes and other conditions and how that has evolved. We are going to describe how to prepare patients for a telehealth visit. And then third, we're going to summarize some of the evidence. And actually, I will, a little bit of a spoiler alert, there is limited evidence, but we'll kind of touch on that. Next slide. So first of all, let's define telehealth. I think we all have a different notion of what this might be. But in technical speak, it refers to any number of different kinds of approaches using telemedicine in synchronous real-time communications. And it does, at least from the the Medicare perspective and definition, includes the audio and visual component for the full kind of reimbursement. And with a patient and a medical professional and their separate locations connected by technology, it used to be that the patient had to be in another healthcare setting, and that has been relaxed. Next slide. So the best data that I could find actually was from the VA. Interestingly, the VA has historically done telehealth. I think a lot more than any other kinds of entities. And so you can see in this slide with the beginning of the pandemic, as with many institutions, video visits climbed up quite dramatically, particularly with, you could see here in mental health, but also with primary care and specialty visits. And the phone visits have paralleled that trend. Next slide. And it's hard to get data on patient trends across the country, but I was able to find some data from primary care providers who were surveyed before, during, and after COVID-19. And so in this was 600 physicians. It was kind of a national sample, and they tried to ensure that the sample was representative by comparing to some population benchmarks. And so this survey was done in 2021, so still sort of towards the, I don't know that was really the end of the pandemic, but for the purposes of this study. So before COVID-19, if you follow the blue line there, that represents the number or the frequency of physicians using, or primary care using telehealth, and before on an often basis before COVID. Then at the middle point is during, and later it sort of tapers off. And then the orange line there is those who were using it occasionally. So that number had continued to increase over time. And those that were never using it was over half. I was actually surprised it was over half at baseline, but then that decreased to less than 10%. So telehealth has remained and seems to have an important place in care. Next slide. However, it actually was fairly limited in its reach. So this was just a recent survey reported out by AHA, 56 million telehealth patients from this claims database. And actually on this claims database, only a quarter of Americans actually used telehealth during this 1.5-year period. And 80% received only in-person care. So the amount of telehealth is actually a lot smaller than, I was actually quite surprised about this. Now, from the perspective of convenience, the majority of physicians and a little more than the majority of patients said it is more convenient for consumers, but only the minority of physicians actually found it to be more convenient. So that takes us to why that might be. So I'm going to hand this over, next slide, to Kelsey.
Thank you for getting us started, Kathleen. I'm going to go over some considerations for what might make telemedicine workable or the best option. A lot of these they apply to multiple illnesses, not diabetes. Cultural competency is obviously a big part of any clinical encounter, but it's something that has to be attended to even more closely during telemedicine, because one of the big advantages of telemedicine is that you can have a patient see a specialist who might not be available in their geographic location. But if patient and provider live in radically different areas, they will then likely have radically different cultural backgrounds, which will impact the quality of care. They might even require a translator in some of the more extreme circumstances. Digital literacy is something I'm going to go over in a little bit more detail in some of our upcoming slides, but sufficient to say how comfortable a patient is using technology is going to have a big part of the encounter. Can they focus on their medical condition, or are they just going to be thinking about their phone and/or computer? As Kathleen said, some physicians are using telehealth more extensively ongoing, and some are less comfortable and shifting back to in-person whenever possible. And that can have an impact for a telemedicine appointment. And this can happen both at the physician and the practice level, how supportive the healthcare system is of telemedicine and what kind of technology and technical support the provider has access to. One of the advantages of telemedicine is that it allows for more frequent interactions with the healthcare system, which can, of course, have a good benefit for patients, especially in terms of mental health care, which can be hard for patients to receive. Specialists are overwhelmed. Systemic, that can be harder to address both at a provider and patient level, but it's just worth pointing out that if, say, you have a patient in a rural area without broadband access or with very limited data availability, so they can only be on the call for a few minutes, that certainly can be an issue. Next slide, please. My research team and I, of which Dr. Rao is a part, last year began to undertake a study looking at the ability of primary care patients who were seniors to have a telemedicine appointment for treatment of a chronic condition such as diabetes, hypertension, etc. So appointments that could be more easily done over telemedicine and that would not necessitate them coming into the clinic, because we did this last year when COVID was still much worse than it is now, and that was a way of protecting that vulnerable population. So we asked about 30 patients who were present at the clinic for an already scheduled appointment to answer 10 questions on areas such as what type of internet capable device do you own? What do you do with that device? Which was a proxy for how comfortable they were with technology and what sort of digital skills they had. Had they had a telemedicine appointment before? What did they see as the advantages and disadvantages, etc. Next slide, please. What we found was that while most of the patients had a device that could theoretically be used for telemedicine, some of the devices that would be best for telemedicine, such as a computer or tablet with the bigger screens so that they could see the provider better or type their responses. Very few of those patients owned those, and even fewer owned smartphones. This is also relevant because often the platforms that best run the telemedicine software, such as Zoom, work better on those devices as opposed to the other smartphone type devices, which was the most commonly owned device. We also found that few had a telemedicine visit, which wasn't surprising, but also few were using their devices for tasks that could theoretically lead to the buildup of skills necessary for telemedicine, such as email, which could be used to schedule an appointment, or video calls with family members, Zoom being the obvious example. And it was quite common for them to say they only use their phone for messaging. The example we gave was WhatsApp, although we can't discount the possibility that they were confusing WhatsApp with text messaging, which could be even less technical. And I also want to point out that few of them were using their devices in ways that would help them to do tasks from home that they would have to go out into the world to do, such as none did online banking, none did online shopping, and how many people do you know who don't have an Amazon account? That's none of these patients. And some weren't using the internet at all. Next slide, please. We found a very clear relationship between our subset of patients who had a telemedicine visit and those who had not had one, excuse me. Patients who had the more quote unquote high quality devices, such as an iPhone, or who were using the more technically savvy and demanding skills such as email, were more likely to have had a telemedicine appointment, whereas quite obviously those who didn't have a device and didn't use the internet hadn't had a telemedicine appointment, but also a large percentage of those who only had a non-Apple phone and who used the device only for messages, which implies that these patients may have a telemedicine ready device, but they lack the skills to really do that sort of appointment. Next slide. We broke this down further by age, looking at patients in their 60s versus patients over 70. And that got us some pretty clear answers, with the younger seniors, if one can call them that, being much more likely to use these more tech-savvy skills such as email, more likely to do things such as video calls, more likely to have a computer and to have had a telemedicine appointment, which kind of circles back to the idea that the patients who are least likely to have telemedicine are older patients, which isn't surprising, but it's also noteworthy since the older patients are the ones who are going to be most vulnerable to illnesses such as COVID and most likely to have mobility issues. So this is a population that is least able to use telemedicine, but also more likely to benefit from it. Next slide, please. We asked patients what they saw as the advantages and disadvantages. Obviously, COVID was a very big concern, and quite rightly so. And patients certainly did not mind not having to sit in traffic and search for a parking spot to get to their medical appointment. But they were concerned about care quality when their doctor wasn't there with them, as well as losing their doctor-patient rapport. As we said earlier, we also found that just because patients have the technology, you can't assume they're ready to use it, especially with these older adults who may need a family member to take over the technical aspects of the appointment for them. Next slide, please. So Kathleen and I looked at some of the telemedicine interventions that are currently out there. And what we found was mostly research on programs fairly similar to the Fit or Me program that Dr. Werner runs. So a telemedicine-based intervention for a specific condition, rather than comparing an in-person versus a telemedicine clinical encounter. And there was so much variety that it was hard to draw conclusions, both in terms of what modality was used, such as Zoom versus an app versus a website, etc. Zoom and video conferencing does seem to be the preferred option. Patients like that they can see and be seen. And if you're talking about an intervention that is, a group intervention, such as a support group, being able to see each other very much helps with the rapport. But it was only in the past couple of years that has really become a more common option. So it's relatively understudied. The more successful traits of these programs, we looked especially at ones related to weight loss and diabetes management, focused on patient self-monitoring. Sometimes this could be through records or through journaling, or it was quite common to use a tracker device, as we talked about last week. And the weight loss modalities also tended to focus on a few key areas, that being portion control, increasing physical activity, sometimes through steps, sometimes through structured programs, and then getting back after the inevitable relapses. Next slide, please. So going back to preparing patients for a one-on-one clinical appointment. These are things that seem obvious to us, but to a patient who hasn't had one before, they're not, particularly if they're not familiar with a device. So things such as making sure their device is ready, charging the device, checking their internet connection, and having all the other apps down so it's ready to go. I know that both Dr. Werner and I have had appointments where we've had to tell them to please focus on the appointment itself and not try to multitask, even though they're at home or in the car. So please don't try to take the appointment while you're driving down the freeway. It can help to have them know that they need a quiet location with all their questions and medications, or any devices such as their glucose monitor with them. And if there's something they need to show to the physician, such as a diabetic patient needing to show the physician his or her feet, like have shoes off, be ready for that. Next slide, please. And I think this is back to Kathleen.
Yeah, so we'll wrap this up with a few sort of pointers in how to conduct video clinics. And really it boils down to having a team. It really runs best if it's modeling an in-person visit. So from all the way from the schedulers who can review the expectations, provide any kind of device specific instructions in an ideal scenario, and maybe that's templated, contact patients after the visit to schedule their follow-up. And so one of the ways you can do this is set up, your schedule template. This is, what an example of what that might look like, so that you have a status button there that you can change the color according to their template, according to their status rather. So we have 4 patients on this schedule, and ideally you get the best video results if you do a pre-call. And ideally that would involve a tech check that would do all the things that a nurse would do when rooming the patient, where possible, including obtaining medication, updating any sort of standard chart elements, health maintenance, things like that, and then obtaining whatever data it is. In my case, it's glucose monitoring data, but it may also be blood pressure monitoring or other physiologic parameters. And so then once that pre-call's been completed, you can see the status there. So they're roomed, that we still need the data, their room is complete, we have everything we need. And then once the provider is done, then you change the dot again, and that is a signal to the schedulers who are reviewing the schedules. So it may not all be in the same continuous format as what we would see in person, but it's all still done. So next slide. And I've reviewed a little bit of this before, but just again, in terms of obtaining glucose data, that is a whole other workflow process. I think that is separate and is complementary to what occurs in in-person visits as well. And in terms of setting up and training patients on their devices, typically you would want to have a designated diabetes care and education specialist, a PharmD, or a trained nurse of some sort. And that is actually working with the patient, training them, setting them up on their app, connecting their app to the clinic, and importantly also documenting how the patient is connected and if they're connected in some way, and then maintaining those portals. And then you can have other staff actually then downloading those reports, uploading them to the EMR. Next slide. And this is also something that I have presented in terms of the types of data that we get. Some of it can be used for remote monitoring visits as well as telehealth visits. And in that case, you have to have data that's digitally transmitted to the clinic. The lowest form of technology is just a patient writes out a glucose log, they mail it, fax it, upload it to a portal. Sometimes that's not as ideal for for telehealth because it really takes some time. But the more tech savvy patients, or at least patients who are connected, can download their device. But honestly, I think the cellular connections tend to be easier because there's nothing the patient has to do once they're set up. And in the future, we will start to see more and more institutions with a cellular connection who have EMRs that have the ability to connect directly from the patient's app on their phone. So we are starting to see that already. Next slide. And in terms of the benefits for diabetes management, the telehealth interventions, there have been plenty of studies that have shown some improvements in A1C, BMI, quality of life. They may not be the traditional, what we're thinking of as an individual visit, however, as Kelsey mentioned. But in this meta-analysis of studies, the best outcomes were actually obtained with any sort of intervention that includes automatic mobile transmission of data or real-time feedback. So those are the two keys, and with a video visit, you get that. And finally, in terms of the broader cardiovascular risk factors, again, when we're looking at specifically synchronous individual telemedicine versus in-person visits, there's some data, but it's pretty limited. And based on, this is one publication that kind of looked at them in a systematic review. And basically what they concluded is that although the data is limited, it seems to be non-inferior to in-person for any number of cardiovascular risk factors, diabetes, blood pressure, and lipids. So with that, next slide, we'll open it up to if there's any questions.
Okay, thanks to both of you. Great presentation, a lot of really interesting points. Any questions for them before we go on? One of the issues I've had with telemedicine, and I think Kelsey set it up correctly, is that patients have to take it as seriously as an inpatient appointment, and that's been an issue. So they often have music in the background, there's people running around, or they're at work, and they don't realize they need to be in a quiet, private space. The other thing we had, because we used a lot of telemedicine during the height of the pandemic, was people no-showing for telemedicine appointments at a higher rate than in person, because one of the things this is supposed to do is to increase access. And I think it's because people just don't consider it to be as serious. They don't realize somebody's waiting for them on the other end to show up. So these are things I think that we have to sort of instill in the culture as we go along. Any additional comments before we move to our cases? Okay, thank you so much. I think we got to turn things back to Claire for a moment.
Thank you. So if you go to the next slide, Rick. You should all have the post survey in your mailbox. If you can please fill that out, we would appreciate it as we're planning for spring. Sorry, I'm cold. As we're planning for spring, we're taking those considerations into account while we plan our curriculum and such. Also, as I mentioned in the chat, we are a little bit short on cases. So if anyone's interested in submitting either their first case, second case, or third case, please let me know. Specifically, we need another case for the next 3 weeks. So just reach out in email and I'll send you a link to submit a case. Other than that, we'll see you guys next week.
Thanks, everyone. Have a good weekend. Bye-bye.